Acute kidney injury has been traditionally defined as an abrupt loss of kidney function, leading to a rapid decline in glomerular filtration rate. This decline in glomerular filtration rate causes accumulation of waste products such as bleed urea nitrogen, creatinine, and dysregulation of extracellular volume and electrolyte homeostasis. AKI usually occurs in patients with previously normal renal function, but may occasionally be superimposed on pre-existing renal disease. That is when we call it acute or chronic renal failure. The incidence of AKI in pediatric intensive care units is around 30 to 40%, with mortality rate of 40 to 50%. Acute kidney injury is defined as an increase in serum creatinine by greater than or equal to 0.3 mg per dl within 48 hours, or an increase in serum creatinine to greater than or equal to 1.5 times baseline within the last 7 days, or it can also be defined as based on urine output, in which a urine volume is less than 0.5 ml per kg per hour for 6 hours. Acute kidney injury is further classified into 3 stages based on rise of serum creatinine or change in urine volume. It's recommended to use kidney disease improving global outcome or KIDGO classification for an early diagnosis of AKI, so that measures are taken to prevent the progression of the condition. Those 3 stages are classified into stage 1, stage 2, and stage 3. Stage 1 is when there is urine output less than 0.5 ml per kg per hour, and stage 2 is less than 0.5 ml per kg per hour for greater than 12 hours, and stage 3 is less than 0.3 ml per kg per hour for more than 24 hours or anuria for 12 hours. And this classification system can also use serum creatinine criteria. By serum creatinine level, if it increases by 1.5 to 1.9 times baseline within 7 days or more than 0.3 mg per dl in 48 hours, we call it stage 1. Increase greater than or equal to 2 to 2.9 times baseline is stage 2. 3 times baseline is stage 3. And also increase in serum creatinine above 4 is stage 3. And also initiation of renal replacement therapy or dialysis is stage 3. And in patients less than 18 years, decrease in GFR to less than 35 is stage 3. The etiology of AKI has conventionally been classified as pre-renal, intrinsic renal, and post-renal. Pre-renal AKI occurs due to inadequate systemic or renal circulation, due to either systemic hypovolemia or renal hypoperfusion. Both pre and post-renal categories can, if prolonged, lead to intrinsic renal failure. Pre-renal can be due to hypovolemia. Hypovolemia can be from dehydration, blood loss, or diabetic ketoacidosis. But the most common cause for pre-renal AKI is hypovolemia, which is from gastroenteritis. It can also be from third space losses, nephrotic syndrome, septicemia, ascites, congestive heart failure. It might be from diuretics. This pre-renal is the most common cause for AKI in pediatrics. Intrinsic renal, it can be from acute tubular necrosis. This acute tubular necrosis can be from prolonged prerenal insult or medications such as aminoglycoside, radiocontrast, or non-steroidal anti-inflammatory drugs. Intravascular hemolysis, hemoglobin urea, snakebite, tumor lysis syndrome can all cause acute tubular necrosis. Intrinsic acute kidney injury can also be from hemolytic uremic syndrome, post-infectious glomerulonephritis, systemic disorders that involve the kidney. All causes acute tubular necrosis and also intrinsic glomerular or tubular damage. Post-renal cause include posterior ureteral valves, urethral structure, bilateral periurethral junction obstruction, ureteral obstruction from stones, stenosis, or urethroceal, or it can also be from neurogenic bladder. Presenting symptoms of AKI include decreased urine output with peripheral or pulmonary edema, suggesting fluid overload. Patients may have altered sensory and even convulsion due to advanced uremia, dyselectrolytemia, or hypertensive encephalopathy. Then breathing might be rapid and deep due to acidosis. The children with AKI due to acute interstitial nephritis or aminoglycoside toxicity, and the perinatal asphyxia are often non-oliguric. They have normal urine output. See clinical feature with the likely diagnosis for AKI. For example, if a child comes with edema, hematuria, and hypertension, especially if the age is between 5 to 50, comes with acute nephritic syndrome, high likely it is acute glomerular nephritis, mainly from post-infectious. Dysentery, pallor, and jaundice might show the presence of hemolytic uremic syndrome. History of fluid loss with severe dehydration can be due to prerenal AKI or functional AKI, and in which case it is not corrected and the latter it causes acute tubular necrosis. Sudden passage of dark urine, pallor, and jaundice might be due to intravascular hemolysis. Interrupted urinary stream and the palpable bladder might be from obstructive uropathy of any cause. Abdominal colic, hematuria, and dysuria can be from ureteric colic. Altered sensorium and the seizure occurs in the case of uromic encephalopathy or hypertensive encephalopathy. Acidotic breathing and pulmonary edema might be from complications of AKI. Investigation for a child with AKI depends on the possible underlying etiology that's identified based on history and the physical examination, and also identifying the potential complications. For all children with AKI, it's better to do complete blood count, renal function test, and electrolytes. We can also send urine analysis if we thought pyelonephritis to be the cause for AKI. We should have to differentiate prerenal from intrinsic renal cause based on history and also based on urine analysis. On urine analysis, in the case of prerenal AKI, since the tubular function is normal, sodium is reabsorbed, BUN is reabsorbed. In this case, urine sodium is low and fractional excretion of sodium is low, and the BUN to creatinine level is greater than 20 in the case of prerenal AKI. Since the tubular function is okay, the kidney can concentrate the urine, so the serum urine osmolarity is high. So in the case of prerenal AKI, sodium in the urine and the fractional excretion of sodium is low, and the urine osmolarity is high, and the blood urea nitrogen and the creatinine ratio is greater than 20. If it is post-renal, BUN to creatinine ratio is also greater than 20, and if it is intrinsic renal, since in the case of intrinsic renal, tubular function is also damaged. In this case, urinary excretion of sodium is high, fractional excretion of sodium is high, and urine osmolarity is low. Radiography, chest X-ray can be done to detect cardiomegaly, fluid overload. Ultrasonography used to identify obstruction, the dilatation of the urinary tract, ECG for hyperkalemia, and investigation to determine the cause such as peripheral smear examination, retic count, LDH levels, and also stool culture if you suspect hemolytic uremic syndrome. We can also do peripheral smear to check for malaria, blood culture if you suspected sepsis as a cause of AKI, ASO titer, complement levels, anti-nuclear antibody, anti-cytoplasmic antibody. If we suspected post-infectious glomerulonephritis, SLE nephritis, and also ANCA-associated glomerulonephritis. Doppler ultrasonography can be done if we suspect arterial or venous thrombosis. Renal biopsy in the case of rapidly progressive glomerulonephritis or non-resolving AKI. If creatinine rises progressively, you should have to do renal biopsy. Micturating cystoretrography is used to detect suspected obstruction. This is the method to differentiate prerenal azotemia from renal causes, in addition to strain the physical examination. In the case of prerenal, as I have said, BUN to creatinine ratio is greater than 20, whereas in the case of renal, it is less than 15. Because in the case of prerenal, tubular function is normal, it will reabsorb BUN. Whereas in the case of renal injury, it is tubule is damaged, so BUN is not reabsorbed. Urine sodium is less than 20 in the case of prerenal, and it is greater than 14 in the case of intrinsic renal. Urine osmolarity is high in the case of prerenal because in this case, since there is intact tubular function, it concentrates the urine. Whereas in the case of intrinsic renal, since the tubular function is damaged, the kidney can't concentrate, so urine osmolarity is low. Fractional excretion of sodium is low in the case of pre-renal and it is high in the case of post-renal. Management of AKI includes the management of complications and treatment of specific underlying cause. To see complications and their management, the first is fluid overload. In this case, insensible doses to be replaced by 5% dextrose and urine output to be replaced by normal saline. Then modify the fluid administration based on serum sodium level. If it's difficult to control the fluid level based on these methods, consider dialysis. Pulmonary edema is managed by diuretics and respiratory support such as high flow nasal cannula and invasive ventilations can be given for severe pulmonary edema. In this case, on the chest X-ray, you see the signs of pulmonary edema and on ultrasound, B-line can be seen. If pulmonary edema is difficult to control medically, dialysis is indicated. For symptomatic hypertension, labetalol infusion, IV furosemide, and for asymptomatic one, oral nifedipine or amlodipine can be given. Metabolic acidosis, if it is severe, IV or oral sodium bicarb is given. And hyperkalemia should be treated aggressively. Stop all potassium in IV fluid and give calcium gluconate or salbutamol and give neutralizing glucose insulin infusion with dextrose. Anemia needs treatment. Packed cell volume transfusion of 5 to 10 ml per kg. And hyperphosphatemia is treated by phosphate binders such as calcium carbonate and the like. Patients with AKI are usually catabolic and have increased metabolic needs. Adequate nutritional support is desirable with maximization of calorie intake. However, volume restriction necessarily during the oliguric phase often impose limitations. A diet containing 0.8 to 1.2 gram per kg of protein in infants and 0.6 to 0.8 gram per kg in older children and a minimum of 50-60 kilocalories per kg should be given. The latter requirement can be met by adding liberal amount of carbohydrate and fat to the diet. Indications of kidney replacement therapy or dialysis in AKI include fluid overload, metabolic acidosis, which are difficult to control medically, refractory hyperkalemia and electrolyte abnormality, and uremia, which is difficult to control with medical management. There are three modalities of kidney replacement therapy or dialysis: intermittent hemodialysis, continuous renal replacement therapy, and peritoneal dialysis. Peritoneal dialysis is mainly for hemodynamically unstable and difficult to access IV line. This is technically simple, no anticoagulation needed, hemodynamically stable, and lower cost and no need for vascular access. No control on rate of fluid removal. The disadvantage is the risk of hyperglycemia. Intermittent hemodialysis is for hemodynamically stable patients. The advantage is rapid removal of toxin, reduced exposure to anticoagulant, and lower cost than continuous renal replacement therapy. Continuous renal replacement therapy is for hemodynamically unstable. In this case, continuous removal of toxin is done continuously, and it is easy to control fluid balance in this case, and there is no risk of increased intracranial pressure. This is all about a summary of acute kidney injury. Thank you for subscribing and watching.